In this video, I am discussing about a video station that is bronchiolitis. So, bronchiolitis, the child age, you know that below 2 years of age, maybe respiratory distress, cough, but the child is can be hospital or can be in home setting. He is active. Sometimes oxygen is present and respiratory distress in the form of subcostal intercostal recession. So we tell that this is a bronchiolitis caused mostly by the respiratory syncytial virus RSV. Age is 6 months to 2 year. Differential diagnosis we can keep like recurrent viral induced wheeze, early asthma, foreign body, cystic fibrosis, pertussis, tuberculosis, post-COVID, recurrent aspiration, GERD, anaphylaxis, congenital lung anomalies, acute exacerbations of any chronic chest disease. History is onset, course and durations, what increase and what decrease, first time or recurrent occur, FWASL, cyanosis or pelo, any choking, drooling, missing toy, any apnea, vomiting or aspiration, family history of atopy. About the vaccination history, exposure to COVID, patient or parent received COVID vaccine, parental history very important, prematurity, parental asphyxia, parental screening. So we understand OCD increase decrease, first time recurrent, FWASL, cyanosis, pallor, choking, drooling, missing toy, apnea, vomiting with aspiration, family history of atopy, vaccination, parental history. Examination, what we do, hydration status, capillary fill time, oxygen saturation, head nodding, chest examination, widespread fine crackles, wheeze, respiratory distress, subcostal and intercostal retraction, hyperinflated chest. Cardiac examination also do for the DD. Investigation, it is a clinical diagnosis except in certain conditions. We do the SpO2 in room air, ABG, capillary blood gas we can do. These are investigation we do. Avoid tests that do not contribute to immediate management. Perform the following only for specific indications like viral nose swab or respiratory virus PCR, chest X-ray, urine electrolyte, blood culture. Blood culture if sign of sepsis, urine electrolyte if planned for IV fluid. So these are the mainly clinical diagnosis. How management? Management is take full history, ABC, oxygen admission if needed, after involving the senior and consultant nurse in the cubicle with head up to avoid the splinting of the diaphragm and clear airway with the careful suction. So ABC, oxygen, ABCD oxygen we are giving. And a nurse in the cubicle, head up positions and careful suction. Respiratory support if oxygen saturation less than 90% or 92% in child less than 3 months, give oxygen via face mask. Okay, 1 to 2 liter per kg according to age. Impairing respiratory failure, SpO2 less than 90% in more than 50% oxygen or in 2 liter per minute oxygen via nasal prongs or cyanotic episodes despite supplemental oxygen. What do you do? Humidified high flow nasal cannula, oxygen 2 liter per kg per minute. If after 1 hour heart and respiratory rate reduced, so treatment is effective. So if not improved, we give the CPAP. CPAP when we are giving no response to humidified high flow oxygen, respiratory rate more than 60 breaths per minute or bradypnea, severe intercostal recession, rise in partial pressure of carbon dioxide more than 3 kPa from baseline, and respiratory acidosis is pH less than 7.20. So as usual, first ABCD we are giving, then we are giving the respiratory support according to saturations. First we are giving oxygen via mask. If not improving, we are giving humidified nasal flow oxygen. If not improving, we are going CPAP. Now about the circulation and the hydration status. Assess the circulation and treat the shock if present. Correct dehydrations if present. If not tolerate oral NG tube, IV fluid we give. What is IV fluid we give? With restriction to 80% using sodium chloride 0.9% in glucose, 5% plus potassium chloride 10 millimole per 500 ml. Check urine electrolyte every 24 hours. So here we give the fluid if dehydration present or shock. Then feeding is normally normal feeds if tolerated. Then NG tube if oral intake is insufficient. IV fluid if respirated more than 80%, persistent vomiting, saturation less than 90% on supplemental oxygen, deterioration of the respiration while on NG tube, and respiratory distress with poor coordination between the sucking, swallowing and breathing. Okay. And then treatment is antibiotic after consultation if there is baby's age less than 6 weeks and patient with temperature more than 39 degrees Celsius, antiviral oseltamivir. We give if symptom less than 48 hour and influenza test positive. So mainly what is the treatment I am telling? ABCD, airway, breathing, circulation, dehydration status. Then we are giving the respiratory support, oxygen, first nasal oxygen, then humidified oxygen, not improving, going CPAP. We are giving IV fluid, dehydration or shock. We will correct that. 80% normally restricted fluid we give, 0.9% sodium chloride. Then we are giving fluid. Normal feeding is indicated, but child has so respiratory distress. Then IV fluid we give. And antibiotic if sign of sepsis in age is less than 6 months after consultation with my consultant. What is the admission criteria of bronchiolitis? Absolute and relative. Absolute are apnea, underlying any cardiac defect, SpO2 less than 92% in room air, inadequate feeding, dehydration and diagnostic uncertainty. So apnea, underlying cardiac defect, SpO2 less than 92% in room air, inadequate feeding, dehydration and diagnostic uncertainty. This is absolute contraindications. Relative are re-attending. So again come the patient age less than 6 weeks, difficult family circumstances, pre-existing any lung disease and any chronic disease. Discharge and follow-up when we give discharge home when fully fit orally and SpO2 more than 90% in air. Hospital follow-up if ventilated on the PICU, consolidation on the chest X-ray, ex-preterm with chronic lung disease, and GP follow-up in all other cases. So these are home follow-up, hospital follow-up, GP follow-up. This is all about bronchiolitis video station. Thank you.